There are two pics, and if you remember these pics by heart, you will understand the whole concept of subtotal cholecystectomy. So in this picture, we can see this is fenestrating type. Fenestration, as I said, we keep it open. So we have on the first picture, we have laid open the gallbladder. The posterior wall is in situ. Only the anterior wall is removed towards the perineal side. And as shown in the inset, we are closing the cystator internally through the GB lumen with the help of pulsing suture. And if otherwise, we can leave the posterior wall of the GB and cystic plate in situ in difficult condition, or if it is coming out easily, we can amputate it partially, but we will not try to go into the hepatocystic triangle, and we'll leave mostly the lower 1/3 of the GB in situ, and we'll keep it open. And at times it may not be possible to close the cystator internally, then we can simply keep it like that and place the rings. Welcome to our channel, viewers. So this will be fifth video on lap chole series, and in this video we have talked about lap subtotal cholecystectomy. That will be lap subtotal reconstituting type, and this is the first part in which we have discussed about the theoretical part, and in the second part we will demonstrate the subtotal cholecystectomy, that will be a reconstituting type in a live surgeries. So friends, if you are watching this video on our YouTube channel, so there's an important announcement that we are shifting all the content to our app-based teaching, as some of the videos and blood surgical videos goes against the community guidelines, and we were worried that our channel may get deleted. So friends, the link for app and official website is available in the description of this video, so please stay connected with us on that platform too. So friends, subtotal cholecystectomy should be in the armamentarium of every surgeon when we are dealing with difficult condition, when the calot is frozen, and when critical view of safety is not achieved. And I hope we'll be able to shed some new light. So stay tuned till the end of this video. So the main objective to learn or highlights of this video will be what is the definition of subtotal cholecystectomy, what are the different types, that is fenestrating and reconstituting type, what is the technical tips for doing so, and advantage and disadvantage of two procedures. And as I said earlier, the live surgery we will upload in the second part, in which we have demonstrated step by step the reconstituting type of lap subtotal cholecystectomy. So we have already uploaded 4 videos in this series, covering from basic to advanced procedure. And if you have not watched our previous video, please do watch that videos before switching to these advanced procedures. So the quick recap: we have already talked about the safe area, the basic tenets of safe lap cholecystectomy for the beginners has been covered in detail with live surgery demonstration. The concept of stop. Friends, this pic is the soul of this whole video series, and if we understand these two lines, for your line, the safe area, most of the time we'll be able to sail safely. And this was the first video, so please don't forget to check our previous videos. How to take clues from the visual anatomy, the surface landmarks, especially in difficult cases, the aberrant right hepatic artery anatomy and how to identify it, how to safeguard, how to avoid the tenting of CBD, partial or total clipping of the CBD. The concept of visual paradox has been demonstrated in one of the live surgery. How to take clues in difficult anatomy, what is a safe area. And in the last video, we had demonstrated open cholecystectomy for residual gallbladder and the aberrant right hepatic artery. So friends, with this background knowledge, let's jump to the this video, that will be a subtotal cholecystectomy. So friends, most of this talk, that is theoretical discussion, will be based upon this paper, that is a PubMed index paper, and I'll share the link in description also. It is by Sir Strasberg, who's a living legend, and he gave this concept of fenestrating and reconstituting type. And if viewers want, they can go in more detail through this paper. So friends, as per this paper and by Sir Strasberg, the term partial Chole should be discarded because it is a non-anatomical description and doesn't convey any scientific meaning. So he gave the concept of subtotal cholecystectomies and it divided into two, that is fenestrating and reconstituting type. And viewers can check on this paper on this link also. So the brief introduction, so there are basically two types, subtotal reconstituting type and another will be fenestrating type of subtotal cholecystectomy. So basically reconstituting is like we are recreating the gallbladder. Reconstituting means recreating. So we are closing the remnant gallbladder and this reduces the incidence of postoperative fistula but creates a remnant gallbladder and there is a possibility of symptomatic cholecystolithiasis. And in fenestrating type, we don't create a gallbladder. So fenestrating means fenestration is something we are keeping an opening. Fenestration is opening. So like we may suture the cystic duct internally, but there are higher incidence of postoperative biliary fistula, and but there are no risk or there is a reduced risk of recurrent cholecystolithiasis. So we will discuss more in detail about these two types. This is the brief introduction. So uh, there are chances that where we can achieve the critical view of safety, as we have discussed in length in all the previous videos, that critical view of safety, that CVS is the gold standard method to prevent biliary injury. And but there should be some safe and effective bailout technique when we cannot achieve the critical view of safety, like when the things are too inflamed or when the calot is frozen. So when a surgeon reached a decision that it is unsafe to proceed with the total cholecystectomy, so there should be one good way out to get out of the dodge, so that the subtotal cholecystectomy is the answer. So based upon the referral pattern, we have observed that many surgeons still believe that there is no good option between cholecystectomy and total cholecystectomy. That is, either there are only two options. Either we can do total cholecystectomy or we can do the cholecystectomy. And anything less than complete cholecystectomy means patient requires a second procedure. But that is not true. And as we evolve the discussion, viewers can understand it better. So another interesting concept which is given by Sir Strasberg in his paper is that when we are removing less than half of the gallbladder or only the fundus is removed, then we should call it fundectomy. And again, I'm re-emphasizing that a term partial near total should be avoided. And then if we are removing more than half, then consider a subtotal, that will be a reconstituting or fenestrating type, and otherwise label as a fundectomy. This will create a common grounds and we can compare the data and will be able to communicate better over a larger platform. So there will be only two type of subtotal cholecystectomy for easier reproducibility. That will be subtotal fenestrating type when we keeping it open, or reconstituting type when we are closing the remnant GB. So, if we are doing subtotal cholecystectomy, what should be our approach to cystic duct and cystic artery? So, friends, historically, surgeon has been trying to ligate the GB in the hepatocystic triangle, even difficult situation when they are doing a subtotal cholecystectomy. So, this is undesirable because these operations will be, required, or you will convert to subtotal type procedure when they are difficult condition, when the calot is frozen. And if we are trying to ligate the cystic duct, cystic artery outside the GB, then there are high chances that will add some extra injury. So under these conditions, the occlusion of cystic duct and cystic artery should be attempted only from the interior of GB, that we can simply ligate with the help of pulse string, or if there is any bleeding from the GB valve, that should be suture ligated. But we should not try to ligate the cystic duct, cystic artery in the calus or hepatocystic triangle. Further, in this situation, if we try to ligate the cystic duct, though historically there has been suggestion that we should try to pass a probe from the cystic duct into CBD, and then try to ligate the cystic duct outside the GB. But again, this is not advisable, especially in these inflamed condition. The probe may pass into the CVD, and we may inadvertently we may ligate the CVD instead of cystic duct. And especially if the cystic duct is short, as it happened in case of the large stone impacted in the neck or the Hartmann pouch, it get effaced, and any probe may pass to a CVD, leading to major biliary injury. So, friends, there are two pics, and if you remember these pics by heart, you will understand the whole concept of subtotal cholecystectomy. So in this picture, we can see this is fenestrating type. Fenestration, as I said, we keep it open. So we have on the first picture, we have laid open the gallbladder. The posterior wall is in situ. Only the anterior wall is removed towards the perineal side. And as shown in the inset, we are closing the cyst internally through the GB lumen with the help of pulsing suture. And if otherwise, we can leave the posterior wall of the GB and cystic plate in situ in difficult condition, or if it is coming out easily, we can amputate it partially, but we will not try to go into the hepatocystic triangle, and we'll leave mostly the lower one third of the GB in situ, and we'll keep it open. And at times it may not be possible to close the cystic duct internally, then we can simply keep it like that and place the rings. So this is the reconstituting type, another type which we will also demonstrate in the live surgery. So again, we can remove part of the posterior wall, or we can leave it in situ if it's difficulty and the things are inflamed. And so we will keep a lip of the gallbladder little bit longer as compared to the fenestrating type, and then we will oppose the two walls of the GB. Of course, we have to evacuate all the contents, all the sludge, all the stones in the neck of GB, and if possible in the cystic duct. And so this will be reconstituting. So we have evacuated the contents. We are not going to the hepatocystic triangle. We will not ligate the cystic duct or cystic artery, and we are staying away from the danger zone, and we are closing the stump. And again, as I said, there is a possibility that there is a recurrence of hepatolithiasis in this type of procedure. So what are the advantages and disadvantages of two procedure? So in fenestrating type, the main biggest advantage will be there is no remnant GB, and there is no or less possibility of later on developing the cholecystolithiasis in the remnant GB. And again, what as closure of the cystic duct is difficult as things are inflamed, so there are comparatively higher chances of biliary fistula with the fenestrating technique as compared to the reconstituting type. So as friends, you can understand in reconstituting, we are closing the GB stump with the help of sutures, so those chances of biliary fistula are less. And based on the presently available information, fenestrating type is preferable because there are lesser chance of remnant GB syndrome and recurrent cholecystolithiasis. But there are no clear-cut data, and our knowledge about this procedure is limited. So, but with the technique or tips to do subtotal cholecystectomy, if we are not, if we think the critical view safety is not possible, or it is too dangerous to venture into the field, to the area of hepatocystic triangle, then the technique will be that we lay open the GB, that the anterior wall of GB is opened till the lower one third. All the stones, sludge is removed, including in the GB neck and cystic duct. And in either type, portion of GB adherent or lever is usually left in situ and ablated. So it is not mandatory to remove the posterior wall. Simply ablate the posterior wall mucosa, and if possible, or it's easily coming out, the part of the GB may be amputated, but it is not, sine qua non that we have to do it. So in fenestrating type, again the GB is open, and there will be lip or shield of GB beyond which we will not go, and the cystic duct may be sutured from inside the GB lumen, will not go outside the GB wall into the hepatocystic triangle. Place at least one or two close section drain to tackle the postoperative fistula, as the chances of post-op bile fistula is high in the fenestrating type, and most of the time it will settle at its own. Or if the biliary fistula is prolonging, then we can take help of the endoscopy of the our medical gastroenterology colleague and placing the stent will easily, ward off the leak. And in a reconstituting type, as I said, the lip is usually larger and will close the two walls with the help of sutures or staplers. Whatever is the preferred technique of surgeon. But I'll advise suturing is better because the staplers, it's difficult to place and sutures are preferable mode of closure of the GB stump. So this is the quick recap of these two procedures, fenestrating type and the subtotal type. Fenestrating type and the regurgitating type. Again, in fenestrating type, we are keeping the GB lumen open and ligating the CD from inside. In the reconstituting type, we are creating a longer lip and opposing the two walls. So in a reconstituting type, the chance of biliary fissure are less, but there are possibility, later on possibility of recurrent cholecystectomy lithiasis in the GB remnant, though we don't have any hard data on this, and which technique should be preferred, even we don't have any answers. So our preferred approach is should be based upon your own experience and expertise of level, and reconstituting type can be easily accomplished with the help of lab, but for fenestrating type usually you require to convert to open procedure. So this is a repetition. So subtotal fenestrating type usually require open, as there's improved ability to suture the cystic duct orifice when the procedure done openly. So friends, the second part will be live operative video of the reconstituting type lab subtotal cholecystectomy, which we will upload soon in on our website and app. For the YouTube, we are facing difficulties, so we may upload with the black and white filter. So please don't forget to check our website and download the app. The description, the link is available in the description. So friends, stay connected, and I hope you like the content. We'll upload the live surgery video soon. So friends, if you're watching this video on our YouTube channel, please don't forget to like the video and subscribe to our channel and hit the bell icon for future updates. We wish you safe cholecystectomy once and always. Thank you very much. Happy learning.